Ready? That means each of you might have to click something at this time, or maybe not. All right. You're okay? Everybody's there. So let's talk about, let me see if I can share my screen. Or I don't think everyday health. This is what was on the top of the page today. Closing the cancer gap. Have you all looked at that today? Nope. Okay, let me see if I can go out to the website for you and share. I like to give you a visual when I can. All right, here we go. You can see that. And now I'm gonna everyday. Can you see my screen? It should be coming. Can you see that? So this is the Everyday Health website. If you haven't yet found it or are joining us for the first time, one of the things that we are trying to provide is a website that gives you the type of information you can trust, and as much of it that you can be informed to share with your friends, or if you have questions that you can go to your doctor with. I thought we would take a look initially at today's top stories. I'll click on it, closing the cancer gap. When you scroll up, what we all know is high mortality rates, less access to care, poor quality of life. These are some of the realities minority groups face when cancer is not equitable. What this is talking about today, and it's going to focus on breast cancer, colorectal cancer, and lung cancer, are the agents of change. And you can read this, but what this is saying to us is there is a reason for hope. While many of the minority groups and low-wage workers and members of the LGBTQ community and elderly residents and people in rural areas and those who don't have insurance are unable to get equitable health, that is changing because there are members of the healthcare community calling modern day heroes who are researchers and clinicians and advocates who are helping to close that gap. And where we can learn about what is happening is you can go through each of these to see and get information that will help to inform us. Next month in December, we're going to talk about breast cancer and the African-American woman. But I thought this was a good way today to kick off our call to see what valuable information Everyday Health can provide. This was just on today's topic, and look at where it lands. It gives you the breast cancer guide. It gives you facts. ACS is referenced here. They're going to talk about colorectal cancer. They're going to talk about the barriers. They're going to talk about the communities, how they're getting screened. And then we can go to lung cancer. And they're going to do the same thing, breaking barriers. It's the same kind of topic. So I'm going to pause there. I'm going to pause and ask if there are any questions, any comments. This was not meant to be a session about breast cancer or lung cancer or colorectal cancer. It was really an opportunity to see how Everyday Health guides you and gives you information that's very, very valuable. I'll pause. All right, we can be didactic. I'm not trying to lecture. But you're good? Any questions? Nothing? I'm gonna see if I can move then to Bari and see if we can show another video. Stop sharing for a second. Go in here. Okay, I'm getting ready to share another time. Now, this should look familiar because this is how you logged in, right? Or you went to there. So if you go straight to the talk session, this is when I was saying, here was your homework. And I called him Middlebrooks Morgan. I think of Smith. That's the other name. Shouldn't. Did you look at this? Let's see. Tell me if you can hear my computer when this should play. It hasn't started yet. Here we go. Oh, that shouldn't have done that. I don't want to do that. Not now. Come on. Sorry, this page is not loading. All right. Are you able to pull that link up, Mark?
I'm going out to check right now. Sorry about that.
No, don't be sorry. I'm the one who's trying to get out of here. Sorry about that, team. I wanted to play at least the one so that you could hear about the treatment and resistance and what's happening, because some people have been asking the question of why. It is that if you take the treatment, you still get COVID after getting the treatment. So,
It loads on my end without a problem.
it did? Okay.
So it might be, I just clicked on it from the website with a control click.
Okay, I'll try that again then. Hold on. Okay.
Are you using a Mac or?
No. See what it does. I see it, but it's still giving me an.
Should I try to share my?
Yeah, just share your screen, Mark.
Moment.
Thanks. You can take control. Anybody can share.
Thank you.
Yep.
Can you, it's saying you need to enable me.
All right. I'm gonna stop sharing, make you the host.
Thank you all for your patience.
Yeah.
Let me know when you've done that.
I'm looking to switch my host. It did say participant. Hold on, Mark.
While Lisa is working on that, I'd be curious to know that of the attendees here, do you find that the use of technology in this way, i.e. going out on the computer, looking at these things with this walkthrough, is this a convenient way for you to access these? Or would you prefer that a more a more intimate walkthrough of these be done in real time as Lisa's doing it? Maybe instead of you going out on your own and clicking through these, you may appreciate logging on to a conversation about it. Does anyone have any preference of which of those is more convenient? Clearly, the on-demand, you going out on your own at your time is more convenient in many cases. Maybe the option of both would work. But if you prefer for there to be a discussion on these topics in real time, I'd love to hear your feedback.
How about an option of both?
Okay.
Any other reactions?
Both. Both.
Okay.
I agree. I say both. This is Kay.
I
And-
like
and-
both as well. That way we can also ask questions if needed.
And Lisa might put me in the headlock for this because I'm I'm speaking out of turn, but I'm almost certain if no other reason, I become more involved in supporting. She's obviously carrying a lot in development of this, and I very much, as I'm sure you all do, appreciate her commitment and passion to all of us for providing this. If you I can't gain access.
Yeah, I'm trying. I'm looking at all settings and I can't switch from the host
Okay,
to it, but that's okay. Let's just have a conversation because the video will be out there for when you come back, if you can access it, but let's just have a conversation. We know that in the first 5 days of getting COVID, there's a prescription that you're able to go and get. And Jane's comments or conversation about that was simply one to say to the masses, you take the full dose and you're still not responding and you still have COVID. What's going on with that situation? Obviously, this virus in each of our systems requires a certain level of medication to be treated. For some people, you don't have the right titer to defeat or to get rid of or eradicate the virus. So the virus is hanging around and not getting treatment. But what you want to do is still isolate and still take it, but you don't want to go and expose yourself to others because there is the possibility of resistance that is taking place when some people know that the medication doesn't work. It's like any antibiotic. When you give something to somebody, and maybe Chike, if you want to talk about drugs in this way, and I didn't mean to put you on the spot, but I know you know pharmacology and you can talk about these things, but the idea is you want a high enough titer to kill that virus. And when you don't have that, it lingers and it can develop, if you keep exposing it to other things, it can develop a resistance and mutate. So you want to be aware of what's happening with that. All right, Chike, come back.
Right here, just switching rooms real quick.
Okay. No.
So I guess antibiotic resistance is caused by, like, I guess, overuse of antibiotics. So when somebody is taking antibiotics and prolonged use of it, that's what causes the resistance. For example, if I'm in the hospital, right, and sorry for the light right now, I'll switching rooms. If an individual is taking a medication, for example, or an antibiotic, such as I don't know,
Amoxicillin.
Yeah.
amoxicillin, right,
There you go.
amoxicillin or clindamycin.
Yeah.
Overexposure to that causes a resistance, as you'll see. And that's something that's funny because when you're using an antibiotic for a very long time, prolonged to the hospital, that's where you'll see like the C. diff and everything that's associated with that from overuse. So I guess like the gut flora and everything that you're using for the antibiotic, it's over time, that's when the resistance develops. That's why they're trying to cut back on the use of antibiotics as much. When things are actually can be tolerated naturally and gradually over time with immunity, they're trying to cut back on that.
So that's a general response to resistance and the antibiotics, which is different than the explanation that Dr. Smith was sharing related to the COVID one. So when you hear that video, she will give a different explanation as to what's going on. But what Chike is talking about is the normal resistance that you can see if you use too much. So, yes.
At least I have a question. In your initial explanation, you mentioned if you do not have a high enough titer. Can you explain that? Because some of us may not know what that is. I don't know what that is.
So a titer is a quantity or an amount of the medication that you want to have that they have in the laboratory determined is enough to kill something. And so they do averages of identifying the amount that is used when they're giving doses of medication. But it's a range or an average. So when you or I get that, it is expected that on average, that medication is going to work and eradicate that. But you may have the virus or have that level that the average dose does not hit and does not treat. So that particular titer did not work for us. So there are those who were with COVID, who still have COVID and didn't get better like others did get better with the 5-day dose. So what Chike is saying is, don't try to take more and more and more of the medication to get rid of it. That's not the objective. You take that, you just don't have the right amount that was for the general public, and you want to get through it. Your body's going to have to fight the regular immune system. Right, Chike? That's what we're saying. So you don't want to, you don't want to go back and try to get another dose of that to try to get rid of it, because then you would be buying into that resistance part. Mark, it looks like.
Does that mean, a question, follow up on that? So does that mean your body is not, the medication is not working, so you just have to fall back on your normal immune system?
Now, well,
or
Hold on.
something.
Chike is going to respond, then I'll let Mark respond.
so not necessarily in a sense. I guess the best way to put it is like, when you're taking the medication and prolonged use of the medication can cause the resistance, right? Now, if there's resistance to that medication, depending on how severe the infection is, right, then you'll have to find another medication that can combat that resistance, right, to that infection.
Mhm.
So think about it like this, in hindsight, right? Let's say you have an infection in your stomach or something like H. pylori, or you're having like ulcers within your stomach. Sometimes people take medications like Tums and all these things, right, consistently, because we feel like it helps our stomach. But sometimes those things are not effective initially when you take it, compared to completely, taking it consecutively over time. So then you get like that resistance to using some of these drug agents, right? And then there's something else that you'll have to do. You have to figure out an alternative regimen. So sometimes taking the medication for the time period that's allotted is better, and that cuts down the opportunity for resistance later on.
Okay. So to your point, Lillian, to take something else is what you were asking, or?
Well, that was my question, I guess. If what you were given for that 5-day medicine, if that's not working after the 5 days, you still have COVID.
Correct.
And you don't feel any better. What's your alternative? What's your option then? Another medication? Or?
At this point in the treatment of COVID, you don't have additional, the regular options that were there outside of that 5 days. So it's not an additional medication that is given at that point.
I'd like to share a perspective from an immune perspective, if that's okay, Lisa.
Sure.
I think it's important if we could sort of categorize the information in large buckets to give us context. What we're talking about here are, number one, the first bucket of your body, your normal anatomy, and your normal physiology. What happens under circumstances when you are healthy versus when you get sick? And that's one bucket. So I'm going to comment about that a little bit. In the next bucket, we are sort of, as we've been talking, we've been dabbling over on medication. which is what happens when you are either introduced to a medication and how your body responds, if you develop resistance or not. Those are not the same. I heard someone make a reference to, if I'm treated and the drug fails, do I fall back on my immune system? And that's a fantastic question. But allow me to put in context the big picture, starting with this. The first thing you have to realize is COVID is a virus. COVID is not a bacteria. So our conversation has been a little bit, joined together because we're moving at a very fast pace. But as a virus, COVID acts in this way. COVID, because if you think of pathogens, that's bacteria, virus, fungus, and so on, they are varying degrees of size. And so some may be cellular, some may have nuclei and what have you. But in this case, a virus is just genetic material. And genetic material is just instructions. So when you write some instructions, you tell your son or your granddaughter or whomever, I need you to go to the store for me and pick up me some eggs, pick up me some milk and some bacon. And here is $10. First of all, that child's gonna be mad at you because $10 can't buy all that these days. But the thing there, the thing I'm getting at is you've given instruction, right? You give the money to the child, you expect the child to go do that. A virus is instruction wrapped in lipid or fat. And the reason why it's wrapped in lipids is because it's just not free-flowing genetic material in your system. So it's wrapped in this fat. And when you get exposed to a virus, it gets in your system, that virus encounters your normal cells. And that virus nuzzles up right against it and says, I'm gonna take over the normal operation of this cell. And it gets that lipid to bond with that cell, breaks the perimeter of it, and inserts that genetic information or that information into that cell. Why is that important? That's the very important thing to understand. Why? Because now, when that information gets put in that cell, it takes over that cell's behavior. And that cell now starts to behave as it has been told, i.e. that kid goes to the store as he or she has been told and buys those items as told. But it's difficult to fight it because guess what? That looks like a normal cell now. It doesn't look like the virus. So your immune system doesn't have the same reaction to it because what your immune system sees is, wait a minute, this is my child, or maybe this is my cell. So I may not respond to it right away. And that's why viruses sometimes escape immunity of the immune system and other things have to come into play, and why sometimes they stay in your body for a very, very long time. And unless there's a cure, once you're exposed to a virus, somewhere within your body, it kind of hovers alone and your immune system keeps it at bay. Now, we're not going to go in that. We don't have time. I hope we can talk about that one day. But hopefully what I've provided is this big bucket that COVID is a virus. Once it's introduced to you, it begins to insert itself in your body functions and begin to have impact. In this case, the impact is some damage to your lungs and various aspects of your body. The lungs, from your respiratory standpoint, it weakens your immune system because your immune system is busy fighting it and other things. And therefore, you may need antibiotics because now you've gotten infected with bacteria that may have overgrown, right? And you have to address that. And so you need some antibiotics to get in there and stop that growth of a bacteria growing potentially in a horrible place like your lungs. And as TK, pardon my mispronunciation, brother, mentioned, that long-term exposure to that, right, might give the virus a chance to overcome, or you may develop an immunity and therefore you may need a different antibiotic. So I'm sorry for kind of, I hope, Lisa, this is good. Please put me in the headlock later, but I wanted to provide some clarity. And if that did, that's great.
Well, that was great clarity, Mark. I think that was really clear, a good way to look at the immune system, differentiate between bacteria and viral, and to understand what the medication is doing in order to treat. So I think that was really clear.
Thank you.
And I kind of listened to what Jane was saying. It's the COVID rebound that is happening when it doesn't work, not resistance. It's COVID rebound. It's what's taking place, so that the virus is not being killed. It's just going up and up and up and up and up to that. So you're still having to fight it and do, as Mark was saying, with your own immune system to try to battle it. So it's just not everything that's getting it done with that, but it's still an option. I would try it no matter what if I had it. And some of you may have already had it and tried it and it worked or it didn't. And if it didn't work, this helps to explain for some why it did not work. So that was what we were aiming for with this one, to be able to explain that. All right. So moving forward, and this will be recorded so you can go back and listen to that. I think in order to address the second opinion, I think this would be a good topic that we can follow up on and see what it is. We have 3 sources on the website now: the WebMD, the Columbia Surgery article, and then the Kaiser Permanente, that give great information that you can have to look at and to reference going forward. I think the first, I read each of them and they were very helpful, I think, in terms of providing guidance. First of all, no one should feel afraid or intimidated to ask for a second opinion, because the medical community, it's an expectation. If you have a physician who gets upset because you say, I would like to have a second opinion, then you aren't with the right physician at that point, because it's your right and everybody expects that. So that's the first thing. I thought that, some people are brave, some people are bold, and some people aren't, but it's our right to want to take care and own our health. That's why we're on the call together, so we feel confident and comfortable about what we're doing together. So why is it helpful? Because you may not like or feel comfortable with the information a physician gave you. You want to know about the risks involved and hear somebody else's take on it. You may want to hear, you don't feel somebody gave you the options and you just want the comfort of understanding that, let me see, gotcha. The comfort and understanding of knowing what someone is saying is true and it's the right thing for you to do. So how do you go about getting a second opinion? Well, first thing is you can ask your doctor that you came from, your primary care physician, to provide someone else that isn't in the same network for that. Or you could ask the physician that you are with the name of another expert that isn't in his practice, and just say, I just like that second opinion. And you don't have to feel like you've offended them when you do that. A very simple way, call your insurance company and ask them, who's in my network? I want a second opinion. That's just a very easy way for you to be able to access what you're looking for. Okay. And in the Richmond area, you've got St. Mary's, you've got VCU. If you were at St. Mary's, you can go to VCU. You can choose within that network, outside of the network if you want, or within the network, you can ask for another physician within that. So when you get that opinion, or you have that, you want to do certain things. You want to make sure that you provide for the person, the physician in that office, the records that you have. You want to set things up for success. If you've had procedures, you've had lab work, you've had things done, you want to provide that person, the physician's office, with that information. so they have as much information, and so you don't have to be subjected to going through additional tests. But they also can go through those records and those tests and see if there may be something that was not done that should have been done, that they want to have done, and they may offer that to you. And or you can go back to the initial one and say, this was something else. So that's basically what you're going to do in order to prepare yourself for that second opinion visit. So that is what I kind of took away from that. Once you have the second opinion, it's your prerogative at that point, based on what you've heard, to decide whether or not you want to go back to the original physician and share what you heard and ask them to discuss the differences, or if you feel from what you have heard, you are more comfortable and you want to stay with the one that you've heard. That's just the prerogative. But I felt it was very straightforward and as easy as that. Now, I might think it's easy, you might not think it's easy, but I think these are some steps that all of us can take and consider what we want to do. And it's always nice to take someone with you when going for a visit, and definitely if you're going for a second opinion. I'm going to pause there. That was the overview that I thought, but there are 3 pieces of information on there, and I just took the information from Kaiser in a general sense to summarize it, to let us know where it was. Any questions? Did that provide, I don't know if the gentleman that was on the last time is on now who asked the question, but for those of you who agreed, because he wasn't the only one, that provides you what you were looking for.
Yeah, I think so. It was Charles McLaurin, I think, who asked that.
Okay.
And because I know he had some issue with the original doctor feeling a little upset he was getting a second opinion, but I think that information was good.
Okay.
I want, do you mind if I say something? So sorry.
Sure.
I just want to give you guys like 2 examples, well, 1 example, and then something just that came to mind. I have a couple who lives in my building. They're older, and the wife, she needed a knee replacement, and she went to an orthopedic surgeon, and the orthopedic surgeon said that she just wouldn't be a great fit for surgery due to her age. But for me, from the standpoint of looking at everything, I'm not an orthopedic surgeon now, but sometimes it's good to look at other places. So I referred her to a physician of color that's an orthopedic surgeon, and she got that second opinion. And he thought that it was okay to do the knee replacement for her. Sometimes in life, we're not presented certain things due to just from the standpoint of race and anything about financial background. So just some small things I've researched lately, just on just outcomes and things that are presented to us. If it comes down to just medications, things that we think that easily could be resolved in our lives, they put us on different regimens due to the standpoint of the color of our skin, or just from the financial means. And I say that to say that it's always good to do your own research and be diligent in that aspect, and also look at other places. And that's just doing yourself a disservice just by going to one person, because what's meant for you may not be meant for somebody else, right? So, they are quick to look over us in that standpoint. So that's why, it's really crucial to do your homework and research on everything that you do, and just don't rely on only one opinion.
That's right. Mhm.
Lisa,
Yes.
I'd like to piggyback off of is this Mark? No, that's not Mark. That's the other Mark. TK.
Okay.
He's absolutely correct. You all know Tara, but anyway, Tara had to have knee surgery, and she had it right before the pandemic, 2020. And the doctor that did the surgery, he was like highly recommended. He jacked her knee up so bad that she went a whole year on walking on a fractured tibia, because this doctor, she was looking at the x-rays because she's a little bit in the medical, even though she's never officially gone to school for it. But she was like, can I see the x-rays? He didn't want her to see them. When she saw him, she was like, what is that right there? Is that a fracture? Oh, no. That's just glue or whatever. It was a fracture. And when she finally went and got, after a year of it hurting, and it was still swelling, and people were like, you had a knee replacement and you still in pain. She went to another doctor at VCU. And when the doctor saw it, they don't want to throw each other under the bus. I understand that. When he saw it, he went, that doctor know better than that. That don't make no sense. So when she had the surgery, it was a 3-hour and 45-minute surgery. When the doctor came out, he said, I apologize. He said, but I had to redo everything. So basically he had to scrape the glue. I don't even know why you would put glue up in somebody's leg, but anyway, I'm not a surgeon. He had to scrape the glue off. Literally, he had to kind of like break it. He had to take pieces out and try to put pieces back in to correct her knee the best he could. And he says, your knee is never going to be like 100%, but I'm going to get it to as close to 100 as I can. And sure enough, that man did. I think she got it about maybe 60 to 70% usage of it. But I mean, hey, that's better than what she had, because what she had was disastrous. And I just was like, I would never recommend that doctor to anybody, because he just blew her off when she kept saying something's not right, something doesn't feel right. The apparatus that he had put in her leg, instead of it being horizontal, they were like sitting like a cross. And she said, something is poking me. Oh, y'all young people, you're just impatient. You all are so impatient of getting better. He didn't listen to his patient at all. And he destroyed her leg. He just destroyed her leg. And she had to go through that process all over again. That's costly because the insurance had to pay for it again. Thankfully they did. But I mean, basically she had her knee redone all over again.
Wow.
So yeah, please take somebody with you, and please ask questions. I know our older people, I'm talking about my mom specifically, they don't ask questions. So take somebody younger with you, or somebody that can ask questions, and just don't listen, don't take the doctor's words face value. They're humans too. And get that second opinion. And if they get mad, so be it, because it's not their body, it's your body.
Also remember, it's just like you're paying for these services. Always remember that.
Absolutely.
It's, don't assume or feel, intimidated by anybody at the end of the day. Just because you tell me to do something doesn't mean I'm always going to follow, right? Patients do it all the time. So why is it that we have to follow exactly what the doctor says?
Right.
So just, be more, advocate for yourself more, and do question these things, and look for other opportunities. So do agree.
When I was a floor nurse, I used to advocate for my patients, because I worked with most of the older population, because it was a rehab floor. And they would come in and the doctors would say, take this, take that. These 14, 15 medications at night. What the world? And the patients I would give them those options. Now, of course, stuff that's gonna, affect their heart, things of that nature. I would definitely advise them to take that, the Coumadin, warfarin, whatever, Lovenox, because I don't want you having a blood clot. But if it was something that they said, no, that makes me sick, that medicine doesn't make me feel well, I would listen to them as the nurse, and I would say, you don't want this medication? No, ma'am, I don't want it. No worries. I would put in the system, patient refuse. I would not make those patients take that medicine, because you know how medication makes you feel. The doctor doesn't know that. You know that. And so, y'all just please, advocate for yourself, and don't just say, oh, well, the doctor knows. No, they don't always know. They don't.
And I think each of you have said the right thing, advocate for yourself. And why we're on these calls is to provide you with information that will help you feel comfortable being an advocate, because you just can't be an advocate because you think you know. you want to be informed enough to be able to feel like something's happening. When your body says yes or no, I think it's appropriate. This is a Lisa response, not a Stephanie or Chike or anybody else. It's, I'm not feeling well. I don't want to take this medication, but you should always let a healthcare provider know why you're not taking the medication, because it makes me feel this way or that way. You should always offer the reason why, not just I'm not going to take it. Because when you stop just taking some medications, it can do more harm if you do it immediately. So I still think that there needs to be guidance. And she's a healthcare provider, so she knows what medication can stop or start in that way. But I think these are just ways that you work with yourself and others and your healthcare provider. Because one of the things that we're also trying to build is not mistrust for the medical community, but we're trying to establish and reestablish trust with the medical community, so that those who are trying to provide good quality health care for all and increase our equity in what we get, that we understand and recognize when it's a good thing that's being done. So we're trying to be self-advocates, but also become more trusting of what the healthcare system is doing, but also be discerning and aware when things don't feel right. Okay.
Lisa, I know we're running out of time, but not to prolong it, but I have a real live example of exactly what you're saying. I was late because my husband just came out of the hospital. Make a long story short, he went in, and when he first went in, they were going to do a catheterization, or at least they thought that was what they were going to do. I said, well, is this an emergency? He said, well, I think we need to do it. And I said, well, tonight? And he said, yeah. Well, anyway, to make a long story short, and I said, well, I would like for his primary care doctor to be involved. He's been treating him for years, blah, blah, blah. Make a long story short, he came home today. He went in Sunday night. He has not had the catheterization yet. He is to go back and see his cardiologist, but they may or may not need to do the catheterization. He does need some follow-up, but they didn't do it on Sunday night when he went into the emergency room. So you do have to ask questions.
And you asked for someone you trusted, the primary care physician who was following him all along, which is wisdom. And that's your second opinion. In a sense, it's like, okay, let's go to that. So that's what we want everybody to feel comfortable doing, making sure that we do that. So thank you. We've gone a little over. Part of that was my inability to share the video and try to make that come to life. I'll see why I couldn't share on this side for the next time. Our next call and bring a friend is about breast cancer in the African-American female community. The video is on berea.org. I got to look at the date, but it's probably the third week in December for us to do, but on the Wednesday, same time. But we did this a little earlier than the last time because we didn't want to run into your Thanksgiving holiday. All of you will be cooking. We appreciate the time. We hope that the information that we continue to bring to you brings comfort and understanding and a way for you to continue the conversations, not just with your own family, but take it to somebody else and invite them to come back and join us again. And if there is a topic or information you want for follow-up, you know how to put the comment in Berea, as well as you can leave it in the chat and we'll look at the chat before we leave. But I hope you felt that our follow-up to the second opinion, showing you how to use everyday health, is making your journey for yourself a better journey.
Okay? And Lisa, can I say just one last thing?
Sure,
since that happened, we have found out that one of his brothers had a similar situation a few months ago. So it may be something that's running in the family or whatever. The bottom line is though, you don't just jump and do it without looking into whether something really needs to be done. So
That's right. That's a good one. Thank you for that. And thank you everyone for asking questions. Ask every and any question all the time. That's what we're here for, having these important conversations. Thank you for joining us tonight and have a good evening.
Good night.
Bye-bye.
Thank you.
Good night.
Night.